I welcome you all to the AIOS-ARC PG Thesis competition, and this is the Young Researchers Award. So a lot of our participants are here. We'll just wait a few moments for the others to arrive. Next slide, please. So by way of introduction, I'm Dr. Tinku Bali. I'm the member ARC North Zone. And it's been a very exhilarating experience the past year to be involved in all the activities of ARC. So as you know, we've been having PG teaching classes every week. We've been having different webinars. And we just now had people who came with their research ideas. We had a competition for that. So we have year-round activities, and this is also a part of the ARC activities. Next slide, please. Next slide. So for this session this morning, we are privileged to have with us Dr. Jyotirmay Biswas as the chairperson. Now, Professor Jyotirmay Biswas is the director of uveitis and ocular pathology at Shankar Nethralaya, Chennai. So by way of introduction, we all know him. He's a prolific writer. He's one of the key persons in the field of uveitis. He's got a humongous amount of articles in so many journals, received 57 awards, including the Silver Award for the topic Current Approach for the Diagnosis and Management of Infectious Scleritis, which is also amongst the most cited APJO articles. And he has a lot of book chapters and books to his credit. We also have with us Dr. Sanjay Kumar Daulat Thakur. Next slide, please. Who is the co-chairperson of this session. Dr. Thakur is the head of Department of Ophthalmology at the College of Medicine and Sagor Datta Hospital. He has had a fellowship in glaucoma from USA. He's won numerous awards from the AIOS, including Best Paper Awards, the Mohanlal Memorial Gold Medal. He also has a huge number of presentations in peer-reviewed journals. And he's an international expert for the National Institute of Health Research, UK. He has been presenting in various conferences, and I welcome him to this session. Next slide, please. So we also have with us a galaxy of judges. So we have Dr. Sudipta Mitra. So Dr. Mitra is the founder director of the RMI Foundation, Hooghly, West Bengal, and she's a senior consultant at the Silver Line Eye Hospital and AM Medical Center, Kolkata. So she has been winning a lot of awards for her work, and I think she's a very apt judge here this morning. She's got the Best Video Award in the Refractive Surgery Film Festival, the Best Video Award in IRSI, the Best Paper Award in the EIZOC Annual Conference, and winner of the IPCL Gold Medal in the Users Meet Bangalore. And presently, she's the Joint Secretary of the Ophthalmological Society of West Bengal. So welcome, Dr. Sudipta, and look forward to having you here. I'll just call out the names of the other judges. Dr. Smita Shukla, are you here? Okay, next slide, please. So Dr. Smita Singh, she's the director, professor, and head of the MGIMS Sevagram, Wardha, Maharashtra. She joined there in 1994 and has been working there since. Excuse me. So she did her Foundation for Advancement of International Medical Education and Research Fellowship from the GSMC Regional Institute, Mumbai. She is also a national faculty for Training the Teachers program, and she's officer in charge of the MGIMS library. She's also the honorary faculty member of the medical education unit of MGIMS, and she's passionate about interactive teaching and promoting e-learning. She enjoys teaching. She's also trained in ocular microsurgery and regularly conducts eye camps. So welcome, Dr. Smita, and look forward to having you. The other judges are Dr. Niladri, Dr. Koyal, Dr. Mahesh Babu. So I request Dr. Jyotirmay Biswas and Dr. Sanjay to please take over the judging. We've already given the judging sheets to them. And with that, we will be starting off with the session. So our first speaker is Dr. Meghna Ganesh, and she'll be speaking on combined corneal biomechanical and tomographical indices in subclinical and form thrust keratoconus. So your time is for 4 minutes. So there'll be a buzzer to tell you about the time. Please stick to the time limits, and all the best.
Very good morning. I welcome you all to the AIOS-ARC PG thesis competition, and we have got an excellent judges, the galaxy of judges, as well as our vibrant moderator, Dr. Pinku Bali, and co-chair will be Dr. Sanjay Kumar Daulat Thakur. Without much ado, we are going to start in time, and Dr. Sanjay will call the first speaker.
Dr. Meghna Ganesh is already on the stage. Please, Dr. Meghna Ganesh. इधर है.
Please start.
Here. I'm Dr. Meghna Ganesh. I'll be presenting on my thesis topic, Combined Corneal Biomechanical and Topographical Indices in Subclinical and Form Cystic Keratoconus. My co-guides were Dr. Ritu Arora ma'am and Dr. J.S. Tityal sir. So firstly, starting with the definition, in my study, I took subclinical keratoconus as an eye with topographic signs of keratoconus or abnormal slit lamp findings with keratoconus in the fellow eye. Whereas form cystic keratoconus was an eye with normal topography, normal slit lamp, and keratoconus in the fellow eye. The criteria for diagnosis was an abnormal localized steepening and a normally appearing cornea on slit lamp with one of the following features: K value more than 47, cylinder more than 1.5, and corneal thickness less than 500 microns. As Ambrosio et al. Correctly said, normal topography does not exclude a corneal ectatic disease. 20% of fellow eyes in unilateral conus, they progress to clinical conus. Hence, we come to our primary objective was to evaluate the corneal topographic and biomechanical parameters in subclinical and form cystic conus and compare them with normal eyes. Our secondary objective was to identify parameters of significance in instances of diagnostic dilemma prior to refractive surgery. This was a cross-sectional observational study conducted over a period of 12 months. We took 15 eyes of form cystic keratoconus and 16 eyes of subclinical keratoconus. We excluded clinically diagnosed keratoconus, corneas with corneal scars, and eyes with prior ocular surgeries. We evaluated 16 pentacam parameters, 15 Corvus ST, and 5 Cirrus parameters. This was students' t-tests were analyzed, area under the curve analysis was done, Jordan's J-index was calculated for cutoffs, and Pearson's correlation was used for correlation analysis. As you can see, our age ranges were same for my study group of cases and control. These are the significant parameters and their subsequent cutoffs, sensitivity and specificity from all the three machines. As you can see, the area under the curve pictorial values, PE and BAD from Pentacam, TBI from Corvus ST, and SIB from Cirrus, they have the highest area under the curve. These are the values indicated in yellow. These are the significant parameters with equivocal sensitivity and specificity from Pentacam, Corvus ST, and Cirrus. These are important for my secondary objective in cases of diagnostic dilemma prior to refractive surgery. These are the correlation results. As you can see, TBI correlates well with cases as well as controls, whereas CBI only correlates well with cases, hence proving TBI to be a superior parameter than CBI. A very important aspect brought to notice by Dr. Ko et al. In her study was she combined biomechanical parameters with topographic parameters like ARC, PRC, and TCT, as stated in the ABCD study for keratoconus. The findings show that they are negatively correlating. So these can enhance the possibility of developing a biomechanical based staging in combination with tomographic indices for subclinical keratoconus as it exists for the ABCD grading in keratoconus. I would like to show you an example. These maps, they show a very normal cornea with thickness on the lower side. But as you can see, the red parameters, the parameters we chose in our study, they are indicating an abnormal cornea. Similarly, the map is very normal in this Corvus ST map, but the indicators are in red, like CBI, TBI, and BAD. They are all in the red, showing an abnormal ectatic cornea. In conclusion, I would like to say that we should always do a combined analysis because in our study we found a higher specificity of 95.4% for PE and TBI combined, 78% and 81% for BAD and SPA1, and 66% and 97% for SIB and BCVB from CIRRUS. Thank you so much.
Dr. Tinku. I now invite.
No, question. Any questions from the judges?
Mike, please.
Yes, ma'am. No, ma'am. It was a Chinese article, ma'am. They were the first to conduct such a study.
What is the implication of your study? How is it going to be clinically
Yes, ma'am.
significant? What is the outcome which is
Yes, ma'am.
expected?
Ma'am, in earlier studies, they had given separate parameters from each of the machines. In our study, we aim to combine those parameters so that whenever there is a doubt in one machine, you can always compare it or add to it by those parameters from the second machine. So our significance is combined analysis to support and justify our diagnosis of subclinical keratoconus rather than just basing the diagnosis on one parameter and going ahead.
Okay, thank you. Anyone?
Thank you.
Have you published it?
Not yet, ma'am. It's in review, ma'am.
Okay.
Thank you.
Thank you, Dr. Meghna. I request Dr. Jyotirmay to.
Ants with retinopathy of prematurity. Is she here? Then I move on to the next speaker, Dr. Dan.
He's not there.
Okay, Dr. Daneshwari Someshwar Gaddi. Is he here? No. Okay, so I move on to the next speaker, Dr. Gautam R. Yes, his topic is comparison of 532 nanometer multi-spot versus standard single spot green laser of PRP in proliferative diabetic retinopathy, a randomized clinical trial.
Good morning everyone. I'll be presenting my thesis, which is comparison of multi-spot PRP versus single spot PRP for PDR in proliferative diabetic retinopathy, a randomized clinical trial. PRP is the gold standard of treatment in PDR. There are two methods of PRP. One is single spot PRP and the other is multi-spot PRP. This is the first study among Indian population to compare multi-spot and single spot PRP using the Zeiss Visualis Green machine, which is shown in this picture. In single spot PRP, sequential spots are applied by moving the aiming beam. These are the usual parameters for single spot PRP, and this is fundus image following single spot PRP. In multi-spot PRP, it is a semi-automated system which applies individual discharges in certain pre-adjusted patterns. These are the parameters for multi-spot PRP usually, and this is fundus image post multi-spot PRP. The primary aim was to compare multi-spot versus single spot PRP in terms of laser parameters and functional outcomes. The secondary objective was to compare the structural outcomes. It was a RCT conducted in JIPMER between 2021 and 2022. 30 patients diagnosed with bilateral treatment-naive PDR were recruited, and these were the exclusion criteria. Consecutive sampling was done. Right eye of each patient was randomly assigned to undergo single spot or multi-spot laser by snooze technique. Single blinding was done and pre-laser examination was done. Each patient underwent one sitting in both eyes on the same day. Number of sittings of laser per eye was 2 to 3 with a time interval of 7 days between the two sittings. Visual analog scale was used to compare patient's pain 5 minutes after each sitting. Follow-up examination was done at 1 and 3 months after PRP. This table summarizes the results. As you can see, in both single spot and multi-spot laser, the spot size was the same. The average power was significantly high with multi-spot PRP. The average pulse duration was significantly low with multi-spot PRP. Fluence is the average laser energy density required. It is calculated using the formula fluence is equal to power into pulse duration divided by spot size. Since the pulse duration was less with multi-spot PRP. The average fluence was also significantly less with multi-spot PRP. This fluence, increased fluence, is thought to be responsible for the collateral damage. Coming to the average visual unlock scale, it was significantly low with multi-spot PRP. The average number of spots per sitting was high with multi-spot PRP, but since multi-spot PRP is a semi-automated machine, the average time taken per sitting was significantly less with multi-spot PRP. All the data were summarized as mean plus or minus standard deviation, and they were analyzed using unpaired t-test. Coming to the functional outcomes, change in BCVA in both the groups was not statistically significant, as you can see in this graph. Structural outcomes, regression of PDR was observed in all the patients treated with either modality. There was no significant difference in pre and post laser macular thickness in both the groups, as you can see in this graph. These are the various studies across the globe using different laser machines comparing multi-spot laser and single-spot laser. As you can see, almost all of them showed that multi-spot laser required shorter pulse duration, had similar efficacy, and was better tolerated. Coming to the strengths of our study, since it was a RCT, it removed bias in allocation of subjects to laser groups. Since 2 eyes of the same patient were used to compare outcomes, multiple confounding factors have been eliminated. Individual variability in pain perception between the 2 groups was eliminated. And since single blinding was done, it eliminated bias in pain perception. Limitations of our study, retinal sensitivity could not be compared using Humphrey Visual Field Analyzer because of logistical issues. Conclusion, average fluence, pain and time taken was significantly less with multi-spot PRP when compared to single-spot PRP. Efficacy of both single-spot and multi-spot laser was similar in terms of regression of PDR, change in BCVA, and macular thickness. These are my references. Thank you.
When it's a very localized, how is the multi-spot will be superior to the single spot?
Actually, our inclusion criteria was only bilateral proliferative diabetic retinopathy, sir. So we included cases with only early proliferative diabetic retinopathy, which required pan-retinal photocoagulation of all the quadrants.
Any questions on that?
Were they affected equally?
Yes, all the confounding factors have been eliminated. The confounding factors. Yes, ma'am. Regression of PDR was observed in all the cases, but the number of. Yes, ma'am. Regression of PDR was noted in all the cases, but the pain perception of the eyes treated with multi-spot PRP was less when compared to the pain perception in the eye treated with single-spot PRP. Also, the laser parameters like average fluence was significantly less with multi-spot PRP.
So main difference is only the pain.
Pain, time taken.
And time taken, okay? But the outcome is same.
Outcome is same. Macular thickness we compared.
And it's also, I think, much more, I mean, less time consume and
better for the patient and the ophthalmologist.
And price is also high.
No, sir, same price. The same machine we has 2 different modes.
Okay.
Same machine we use the 2 different modes.
Pain is less.
Pain is less because of the less average fluence in multi-spot PRP.
One question, why is the pain less according to you?
Because as shown, the average fluence was less with multi-spot PRP because it uses shorter pulse duration. So the pain perceived by the patient was significantly low. The fluence is responsible for the collateral damages like pain.
And there's one little ethical question which I'll ask, is that when you're very sure that it is better, would you like to continue with the study again?
Earlier studies showed that single spot laser was a bit more effective than multi-spot PRP. So we wanted to compare and find out is it actually true. But in our study we showed that both are of the same effect, but multi-spot PRP has less side effects. So ethical clearance was obtained from our Institute Ethics Committee.
How did you randomize the patients?
Block randomization using snooze technique, ma'am. Sealed envelopes.
What was the duration of follow-up?
Duration for follow-up 1 and 3 months, ma'am. First examination was done at first month and third month.
Do you think it will make any difference if you follow up for
that retinal sensitivity could have been analyzed at 6th month to see the field changes, but because of logistical issues in our hospital we couldn't do that.
Okay.
What about publication?
Publication manuscript I have prepared, ma'am. We are sending for.
neodymium, yttrium, aluminium, garnet, laser. That is better to talk NDR, capsulotomy on corneal endothelium.
Very good morning, everyone. Myself, Dr. Vibha Singh. I am working as a specialist at the Burari Government Hospital, Delhi. I did my thesis at the Hindura Hospital, Delhi, under guidance of Dr. Betik Chaudhary and Dr. Anurag Anand. My topic is the NDR laser is safe procedure for posterior capsulotomy. There is no financial interest. Cataract is responsible for over half of blindness worldwide. Cataract surgery is most commonly performed ocular surgery. Posterior capsular opacification is one of the most common late complication of ocular surgery. Cataract surgery, the frequency of PCO after cataract surgery is 1.6%, 12.3% and 26.5% at 1, 2 and 3 years respectively in a different studies. So current treatment of choice is the NDR laser capsulotomy. Although it is safe, give a instantaneous result and can easily be administered in an outpatient department, it has some side effect. So my research question was, what is the short-term effect of NDR laser capsulotomy on corneal endothelium? Aim and objective. Primary objective is to assess and compare the endothelial cell count pre-capsulotomy with immediate post-capsulotomy at 1 week and 1 month. Secondary objective is to assess the outcome of the NDR laser capsulotomy in form of the best corrected visual acuity and study to correlate the total laser energy used with the effect on corneal endothelium. This study is a prospective observational study. Total 150 patients with PCO undergoing a capsulotomy between April 2018 to 2019 at a Hindura hospital in the OPD department. Study population was concluded in our outpatient department. During the study, we just observed the result which is summarized in a table. In a 150 patient, mean duration of the development of the posterior capsule opacification after cataract surgery was 18.4 months. It is also present in a bar chart. The side effect, early complication of the AIOC laser capsulotomy is in bar chart. Total 150 patient, early post-operative complication was aqueous flare 32%, followed by a transient rise in IOP 29.3%, vitritis 8.7%, bleeding from the iris is 8% and pitting of IL is 6%. So changes in visual acuity, we can see before procedure only 10.7% of the cases had a visual acuity 6/24 or better, with mean visual acuity improvement significantly after a laser capsulotomy in 76% in immediate post-op and 81.4% within a week and 94.7% by the end of 1 month. Mean changes endothelial cell count after NDR laser capsulotomy, which is in 150 patient, the endothelial cell count decreased. Pre-capsulotomy it was 2245.6 cell per millimeter square, which is decreased to 2174.4 cell per millimeter square after capsulotomy, and then 2093 98.3 cell per millimeter square with after end of 1 month, which is significant. Second variation we can see in a hexagonality, which is also significantly decreased to 72.4% to 70.22% by the end of 1 month, which is significant coefficient of variation. There is no significant changes in coefficient of variation. So we can, after posterior capsulotomy, we can see the mean hexagonality of the corneal cell significantly decreased, and after which is significant. To conclude the topic, mean total energy was used 72.2 millijoule and mean number of shot required 22.1 during the procedure. Early post-operative complication we already discussed, and mean visual acuity improvement we already discussed. So there is a significantly inverse correlation was observed between the energy used for NDR laser capsulotomy and endothelial cell density. To conclude, in nutshell, NDR laser capsulotomy is non-invasive, cost-effective, and a rapid procedure that can be performed in an OPD department with a method of choice as compared to the surgical dissection. NDR laser has a fewer complication. It is more safe, convenient, and effect. However, laser energy level should be kept to minimum so that complication of the procedure to be kept minimum. The shortcoming is it is a short-term study. We cannot have any comment on the long-term effect of the NDR laser capsulotomy on endothelium. Thank you.
Is there any difference between the thick capsule and the thin capsule?
Yes, sir. We have to give a more energy and more number of shots.
any difference in outcome?
Sir, endothelial cell maybe less than the in thin and thick. We have to use more energy and more
No,
short.
that's okay.
You do a correlation between
Correlation between that two.
the grade of
We just take
TCO
randomly
and
the
the
patient.
energy
We just take randomly the patient as
This could be one of the
another
things which
study.
you could have studied.
Energies always require more when you have a thicker number of shots.
Yeah.
So that has to be correlated.
We can do another study.
What do you think is the mechanism of endothelial damage?
There is a shock wave formation. That's why biomechanical change that may cause a damage to the endothelium at
This endothelial cell count was done once only or was it repeated?
first pre-capsulotomy, after capsulotomy at 1 week and 1 month. Because after 1 week patient due to the
Again, I think a long-term follow-up would be a better insight into this, and a correlation, as sir has said, with the grade of the opacity and the energy delivered. Thank you.
He'll be speaking on a comparative trial, topical interferon alpha 2b versus low-dose tacrolimus for vernal keratoconjunctivitis.
Good morning everyone. I'm going to present today my thesis topic, a comparative evaluation of efficacy with topical tacrolimus and topical interferon alpha 2b in treatment of vernal keratoconjunctivitis. My guides were Dr. Taskin Khan ma'am and Dr. V.S. Gupta sir. VKC is seasonally recurrent conjunctival inflammation presenting with just irritating allergic eye disease to vision threatening condition, found twice as common in the young boys than the girls. It generally presents with the symptoms like eye itching, foreign body sensation, burning sensation, and signs like Tranter spots, limbal hypertrophy of papillae, superficial keratitis. The pathogenesis can be summarized in the following flowcharts, where we can see the various mechanism by which the allergy was stimulated. So conventionally, we have been targeting this flowchart with steroids to the antigen presenting cells, with the mast cell stabilizers or the antihistaminics. The newer thing we have got is the immunomodulators, that are the interferon alpha 2b and tacrolimus, which acts on T helper cell 2 and the IgE. So we decided to study the efficacy and the side effect profile of interferon alpha 2b with topical tacrolimus and the treatment of vernal keratoconjunctivitis. The patients with VKC were selected. They were explained the nature of the study and obtain an informed consent with the participant and randomly allocated into 2 groups. The patient were assessed at 2 weeks, 1 month, 2 months and 6 months based on the clinical scoring system given by the Blake et al., where the total subjective symptom score were graded from 0 to 3 and the total subjective sign score was graded from 0 to +3 in following manner. We found that 80 patients of VKC were randomized into 2 groups of 40 each. The average age was between 7 to 11 years and 3:1 male-female ratio was seen. The total subjective symptom score with group A was seen at the baseline of 6.87, which gradually improved over the weeks and was found significant at the end of the 4 weeks, which was highly significant at the end of the 8 weeks with 0.61. Similarly, in the interferon group, we found that it was significant at the end of the 4 weeks, and at the end of the 8 week, it was again highly significant. Also, the side effect like burning sensation was seen in few patients, but it did not require any active intervention. No side effects were seen with the interferon alpha. Also, the subjective sign score showed an significant improvement at the end of the 4 weeks, and at the end of the 8 weeks, it showed a highly significant change. Similarly, in the interferon, also it was showed a significant at 4 weeks and highly significant at the end of the 8 weeks. The graph also shows that there was a progression improvement in the symptoms and the signs scores. Even after stopping the drug at the 6 weeks, it continued to improve till the 8 week, though it showed a remission at the end of the 6 months. Treatment of VKC is a challenge. We have the conventional treatment like mast cell stabilizers, antihistaminic, corticosteroids, but the immunomodulators are the newer one. However, none of these agents abolish all of the signs and symptoms are side effect free. The tacrolimus and interferon was used in the study keeping in the mind the recurrence rate and the side effect profile of the conventional treatment. Previously, multiple studies has been carried out, but those all have been selecting the patient with refractive cases or the non-responders. Here we tried to break this stereotype and started the immunomodulator as the first line drug. We concluded that both tacrolimus both the tacrolimus with 0.03% was significant improvement in TOS and TSS at the end of the 6 weeks, but it again recurred at the 6 months. Interferon alpha 2b showed a statistically better improvement and better tolerability, concluding that both tacrolimus and interferon are safe and effective, but a long-term show remission at the long-term follow-up. Limitation of our study was that there should be a systemic tapering of the drugs and longer follow-up need to be taken. Thank you.
Asking the clinical significance.
The interferon showed better results than the tacrolimus, not in wise the improvement in the sign and symptom, but the side effect profile was better with interferon. Tacrolimus has always been with a burning sensation problem with the patients, which interferon didn't show.
Burning side effect, what is the difference between the steroids and these things?
Steroids generally come with the glaucoma increase.
No, budding the side effects.
Sorry. Cost-wise, the tacrolimus comes at 328 rupees, and interferon, the injection which we used to do is 541 rupees, which used to give a 20 days.
No, my question is, what is the efficacy between the steroids and
Regarding the
tacrolimus
efficacy,
and
what is the difference
interferon
between
too?
Currently, in my study, we hadn't compared it with steroid, but I am undergoing with that process.
Okay.
Yeah.
Cost-wise, is there a major difference?
Cost-wise, if we see that steroids are really cheaper than this, but they come with the side effect as well as the recurrence thing. And if you go for interferon, it comes at 541 rupees, 20 days drop you can prepare with that thing. So if it prevents the recurrence, that is the main target the patient would like.
But I think you showed in your graph that at 6 months there was a recurrence.
Yes, there was a remission in that, but it was significantly below the baseline. It was still.
But you are not comparing with steroids, so we don't know.
Yeah, that's
vis-a-vis what happens with steroids, we can't comment.
Yes, sir, we need to take that comparison.
Have you published this?
It is under process, ma'am, in cornea.
What was the original hypothesis?
To compare between the tacrolimus, effectiveness of tacrolimus and interferon, effectiveness and side effect profile of the both, whether one of them is better.
Okay.
Thank you.
Thank you, ma'am.
Thank you, Dr. Saurabh. So I request Dr. So I will call the next speaker. So our next speaker is Dr. Hitisha Mittal, and she'll be talking on the rescue of conjunctival lymphatics with retinoic acid after mitomycin C-induced inhibition in rat eyes. Dr. Hitisha.
Good morning, everyone. I'm Dr. Hitisha, and I'll be sharing my thesis with you all, which was titled Rescue of Conjunctival Lymphatics with Retinoic Acid after Mitomycin C-Induced Inhibition in Rat Eyes. We know that the post-trap bleb drainage is via aqueous veins and episcleral vessels. However, studies have shown the presence of lymphatics in these subconjunctival blebs. Studies have also shown the toxic effect of mitomycin C on these lymphatics and vascular channels. On further literature research, we found that retinoic acid has lymphangogenetic properties which are under evaluation in experimental animal models. So we came to this question, can we counteract the MMC-induced damage to lymphatics using retinoic acid? So the aims and objectives of my thesis were to see the effect of MMC on these lymphatic channels and to see the effect of simultaneous usage of MMC and retinoic acid on these lymphatic channels. It was a prospective experimental animal study done on 30 Sprague Dawley rats divided into 5 groups. The right eye of each group was the intervention eye and the left eye was control. The intervention in group A was with balanced salt solution, in group B with mitomycin C. Group C was the dose standardization group for retinoic acid, where we started with 10 nanomole concentration. However, due to lack of effect, we increased it to 100 nanomole. Group D was the combined MMC and retinoic acid group, and group E was the DMSO group. After appropriately weighing the rats and giving intraperitoneal anesthesia and under sterile aseptic precautions, we used a 30-gauge needle to inflict injury in the subconjunctival tissue and formed a subconjunctival bleb as per each group specification. And on post-operative day 14, we enucleated and the conjunctival samples were analyzed in the pathology lab for CD31 and D240 markers. We saw what was the lymphatic and blood vessel density in these groups and what was the effect of MMC and retinoic acid on these draining channels. Appropriate statistical tests were used, which led us to the following results. Mitomycin C had a significant reduction in the conjunctival lymphatic count. However, in the combined MMC and retinoic acid group, there was a dramatic increase in the conjunctival lymphatic count. These are the histopathological slides. The first one shows the normal conjunctival tissue. The second one shows the increase in lymphatics when a local injury is created. Now in the third slide, we can see there is a decrease in lymphatic count when MMC is applied. And in the fourth slide, we can see there's a dramatic increase in the lymphatic channels when we give retinoic acid along with mitomycin C. We also analyzed the blood vessel count and we found that the combined MMC and retinoic acid group had a higher blood vessel count when compared to the other groups. Similarly, these are the histopathological slides for the blood vessel analysis. The first one is the normal conjunctival tissue. The second one shows the increase in blood vessels when a local injury is created. The third one is the post-MMC slide, and the fourth one shows the increase in blood vessels post-MMC and retinoic acid application. So to conclude, MMC has a toxic effect on the developing conjunctival lymphatics, potentially causing bleb drainage failure. Retinoic acid has lymphangiogenic and angiogenic property at 100 nanomole concentration, and simultaneous application of retinoic acid with MMC can reduce the MMC-induced inhibition of lymphatic and vascular channels. These were the merits and demerits of my study. I would like to thank my mentor, Professor Pandav sir, for giving me this opportunity. Thank you very much.
What immunohistochemical marker which you have used and what it stains?
So we used two immunohistochemical markers. One was CD31 that stains the vascular endothelial cells.
Okay,
So
correct.
that tells us about the blood vessels. The second one was D240, which is commonly known as podoplanin. That is the lymphatic endothelial marker. So we created different sections to stain with CD31 and D240 and separately analyzed them.
Wonderful.
Yes.
Did you consider the role of matrix metalloprotease in breakdown of these collagen fibers? Matrix metalloprotease, MMP. In scleritis or any other inflammation, the matrix metalloprotease plays an important role.
Yes.
Even diabetic retinopathy, matrix metalloprotease plays an important role in degradation of the collagen fibers and the walls. Did you consider, or it is in your hypothesis?
Sir, we did not consider that in this particular study because it would be common in all the rats. We thought it would be a common factor, so it would not specifically decrease lymphatics or specifically decrease the blood vessels.
I would like to congratulate you because this is the original research work.
Thank you so much, sir. Thank you, sir.
I would just like to know if Dr. Virendra Kumar is here. No? Okay. So I think yours is the conclusive talk. So I request Dr. Niladri Saha and Dr. Koyal Chakravarti to please present a certificate to Dr. Hitisha.
I have given that form.
Yeah, I gave it to her. Feedback from her. You just give this. Before finishing, I would like to confirm whether Dr. Meera Nair and Dr. Daneshwari have come. No, okay.
Yeah, that's good.
Let's take a group photograph.
So I thank you all for being a part of this session. I congratulate all the speakers for their wonderful presentations and the judges who were here. Thank you all. Thank you to my chairpersons also. May I have the last slide, please, for this session? The last slide, there was a slide, the last slide. So there'll be another session. There'll be the people who will be selected from this session. They will be having another competitive session, which will be, Shilpi, in the afternoon? which will be in the afternoon, the second round. Yeah. So the top 10 people will have to present again in the final round at 2 p.m. in the same hall. So please be here and please find out if your name is there, and please be here at 2 p.m. So thank you everyone once again.
Group photo.
And yeah. Yeah, so we also have